Hi and welcome to Dad's Vlogs. Hi and welcome back to Dad's Vlogs. So, we're back in the shed today so I can finally make good on a promise. A few people have asked me to make a video on how I do a spinal catheter. I've used spinal catheters for difficult cases for more than 20 years now, and I've found them incredibly useful for those patients who are, not fit for a haircut. A few colleagues have asked me for a straightforward approach to this technique. So, here goes. We'll start with why I use spinal catheters and what they offer. Then we'll tackle why many anaesthetists avoid them. We'll cover when you should not be using them. And finally, I'll walk you through placement, dosing, and how to make this technique work for you reliably in day-to-day practice. So let's jump into why I use them. For me, the spinal catheter solves a number of problems. A good spinal block can allow a patient to avoid a general anaesthetic. But sometimes a single shot spinal just won't cut it. Spinal catheters offer you 1. Slow titration. A spinal catheter can be topped up gradually. Almost any patient can tolerate a slowly evolving block and the resultant sympathectomy. Fractionated dosing gives physiology time to adapt, especially if fluids and vasopressors are started during that titration. Number 2, there's no overshoot. You can stop dosing the moment you achieve adequate surgical anaesthesia. No need to overshoot the block and hope for the best. Number 3, rapid extension. If surgery runs longer or changes unexpectedly, the block can be extended quickly and easily. And, importantly, unlike an epidural top-up, spinal top-ups work really fast. Number 4, unlimited duration. The block can essentially be maintained indefinitely with repeat boluses. Number 5, reliable density. Unlike the epidural component of a combined spinal epidural, the block is dense and predictable. No patchy segments. No unilateral surprises. Number 6, certainty of placement. You always know where your catheter is. If you can aspirate CSF, you know it's intrathecal. There's no equivalent reassurance for an epidural. Number 7, tiny local anaesthetic doses. You need remarkably small doses of local anaesthetic to achieve a dense block. That leaves room for additional regional techniques without running into maximum dose limits. Over time, I've come to think of the spinal catheter as IV access to the CSF. Once I have a catheter that aspirates freely, I relax. I know I can provide safe, reliable anaesthesia for as long as I require. When I place a spinal catheter, I usually target the low lumbar spine, L5-S1, L4-5. From there, I can reliably cover the sacral roots and then extend the block carefully with repeat boluses. I often choose a spinal catheter in patients with very limited cardiac or respiratory reserve, where a single shot spinal could feel like, a bit like stepping off a cliff. I also use them when duration is uncertain, and where conversion to a general anaesthetic halfway through a case will carry real risk. And I work in a teaching hospital, so as you might imagine, lower limb cases often run, significantly longer than advertised. For me, spinal catheters are particularly useful in patients with severe aortic stenosis, cardiomyopathy, pulmonary hypertension, or severe COPD, to name but a few. Now, many anaesthetists feel uneasy about spinal catheters, and honestly, I think that's understandable. So let's talk about where that anxiety comes from. Number 1 must surely be post-dural puncture headache. The first concern most people express is about this risk. Most folks associate dural puncture headache with their accidental obstetric wet tap, and that sort of experience can stick with you. But spinal catheters are usually used in older patients where the baseline risk of post-dural puncture headache is already much, much lower. I also use a paramedian approach, creating an oblique tract through the dura that may help form a self-sealing flap valve, which could lower the risk further. I place many spinal catheters every year, and personally, I've never even had to review someone for a post-dural puncture headache, let alone treat one. Second on people's list of concerns is nerve injury, and in particular, cauda equina syndrome. A number of cases were reported in the US and in Europe in the 1990s, and these devastating cauda equina injuries were associated with microcatheters, and these were 32 gauge in size and were used in conjunction with 5% hyperbaric lidocaine. I'll cover that story in more detail in a future video on baricity and spinal blockade. These days we don't use microcatheters, we use epidural sets. I use a standard 18 gauge epidural set, and I use plain 0.5% bupivacaine. In my 20 years, I've not encountered nerve injury as a complication. That's not to say that it cannot happen, but rather it is quite rare. Third on people's lists of concern is infective things such as meningitis. Now, people worry about infection or meningitis, but in practice, I think the risk of this is incredibly small. One of the reasons for that is catheters only stay in for a short amount of time, just the duration of the surgical event, and then they're removed. When they're placed in patients who are receiving perioperative antibiotics for their surgery, which I think also lowers the attendant risk. Number 4, the emotional issue. Honestly, I think this is one of the biggest unspoken barriers to using spinal catheters. As anaesthetists, we're trained to see CSF pouring out of an epidural as, well, abject failure. We feel this failure deep in our bones. It's part of our DNA. This technique asks you to reinterpret that moment, not as a disaster, but as an opportunity. Yes, you might squeal the first few times you put your epidural needle into the CSF and look around nervously to see if anyone else saw that CSF fountain. But it may well be worth mastering this fear so you can get all the good things that a spinal catheter can offer you and your patient. All right, continuous spinal anaesthesia, great technique in the right patient. But like everything we do, it's not about can you do it, it's about should you do it. Let's start with the easy bit, absolute contraindications. They're pretty much the same as any spinal. Patient says no, infection at the site, unsafe anticoagulation, uncorrected hypovolemia, raised ICP from a mass, VP shunt, or that unicorn, true local anaesthetic allergy. If any of those are there, you're just not doing one. Now the real world, relative contraindications. Sepsis, borderline anticoagulation, severe cardiac disease, bad backs, previous surgery, known or suspected severe spinal stenosis, or a patient who just can't cooperate with you. None of these are automatic no's, but they should slow you down, make you think, is this really my least worst option? Alright, so I get asked this all the time. What equipment do you actually need to put in a spinal catheter? And the answer is, honestly, pretty simple. You're putting something in for intraoperative use, not for long-term analgesia, so you don't need anything too fancy. Most of the time, just a standard epidural set. No need for an expensive, dedicated spinal catheter kit. Now, there's one key thing to think about. You're usually placing these lower in the lumbar spine, and you're often using a flat, paramedian approach to the interlaminar space. That means more soft tissue to get through, a longer, more oblique path, and effectively a deeper target. So, choose your weapons accordingly. Longer epidural needles are your friend here. What works in for a midline epidural might not reach comfortably in this setting. Now let's talk needle size. I tend to recommend an 18 gauge epidural set. Why? Because it's a really nice middle ground. You get really good CSF flow to confirm dural puncture. The catheter is easy to aspirate from, and you can eject through it reliably. At the same time, you're not making as big a hole in the dura as you would with a 16 gauge set. And that likely means a lower risk of post-dural puncture headache. So in summary, keep it simple. Standard epidural set, go a bit longer on the needle, and I reckon the 18 gauge is a really sensible compromise. Righto, let's talk patient positioning. Now, can you put a spinal catheter in with the patient sitting? Yes, you can. But in my practice, I almost always use the lateral position. And there are a few very practical reasons for that. First up, the patients. A lot of these patients are elderly patients with lower limb fractures. Getting them to sit up is often painful, awkward, or just simply not realistic. Rolling them gently onto their side is usually simpler and kinder. Second, stability. Patients in the lateral position are just less likely to faint, less likely to topple over, and it's a much more controlled setup. Thirdly, sedation. In the lateral position, I'm much more comfortable giving a bit of sedation. There's less airway risk, less chance of the patient becoming unsteady. It just feels safer. Fourth, positioning cues. Patients seem to get the curl up instruction much more intuitively when they're lying on their side. You get better lumbar flexion with less coaching. Now the next point is probably the biggest one for me, ergonomics. I'm usually targeting L4-5 or L5-S1, and I'm using a paramedian or paraspinous approach. That means the needle is coming from a caudate direction with quite a flat trajectory. And here's the problem in the sitting position. Your hands end up very close to the bed. The angle can feel cramped and awkward. In the lateral position, I find I can adjust the patient position, adjust the bed height, and get a much more natural working angle. As I insert the needle with a paramedian approach coming from the dependent side of the patient, this ensures very good CSF flow, even when CSF pressure is low. So for me, lateral wins. Easier for the patient, safer with sedation, more stable, better positioning, and a much nicer ergonomics. When you're working low and flat, that's Dad's take. One of the important reasons for placing the catheter L4-5 or L5-S1 is to do with the ability for the local anaesthetic to spread. The dural sac ends in a blind-ended pouch that contains the sacral nerve roots. From a practical point of view, it is always easier to get local anaesthetic to spread up the thecal sac than it is to thread down. So if your starting position is high up in the lumbar spine, then it can be a problem where you might miss the sacral nerve roots, and therefore your spinal catheter may fail you. Staying at L4, L5 or L5-S1 keeps your advancing epidural needle a long way from the conus medullaris. The last thing you want to do is to damage the conus with a large epidural needle. You do not want to cause a syrinx or damage to the conus. In this video, we can see me infiltrating the patient with local anaesthetic prior to placing the spinal catheter. I put my thumb into the space of L5-S1, and you can see I'm infiltrating the skin off of midline over the sacrum. I'm using the local needle as a seeker needle, and I'm feeling the sacrum underneath the needle tip. So I'm instilling local anaesthetic as I go and identifying the anatomy of the sacrum as I walk in a catheter direction. When I insert a spinal catheter, I aim to place it at the L5-S1 interlaminar space. This keeps me as far as possible from the termination of the spinal cord. It also allows me to get my local as close as possible to those harder to reach sacral nerve roots. I use a modified paraspinous approach. As you can see on the picture on the left, I find the spinous process of S1, walk off laterally onto the sacrum, as seen in the picture on the right. Once my needle tip is on the sacrum, I walk my needle in a kefale direction up the sacrum. The key is to make many small needle angulations and reinsertion. The commonest reason for difficulty is too much reangulation of the needle. These larger corrections can cause the needle to pass right over the interlaminar space to contact the lamina of L5. I tell my trainees to make such small reangulations that someone watching you would struggle to see them as such. Aim for multiple small, swift reinsertions that allow you to feel your way along the sacrum in the manner that a visually impaired person can use a cane on a footpath to find their way. You should aim to feel the bone at the end of each reinsertion. As with all paraspinous or paramedian techniques, the great benefit is that you only need to recognize bone or not bone, rather than subtly changing ligamentous feel, as with a midline approach. In bones we trust. I feel the lip of the interlaminar space rise up just prior to engaging ligamentum flavum. My needle is passing through ligamentum flavum in an oblique parasagittal plane. This means the flavum feels quite thick, due to the oblique path and the flavum being thicker laterally. This can initially be unsettling to those used to midline epidurals and spinals. With time, however, this becomes a reassuring confirmation of your location. If you use a paramedian or paraspinous approach to placing a spinal catheter, it means you enter the dural sac obliquely and on an angle. This allows you to virtually cannulate the thecal sac and makes it a lot easier for your catheter to advance out of the needle. Having watched the preceding video, where I advance the needle along a spinal model, we're now going to look at me do the same procedure in the patient. First off, I put my epidural needle onto the sacrum in a paraspinous orientation. I then walk up the sacrum with multiple small steps, feeling the bone of the sacrum as I go. I'm looking for the edge of the L5-S1 interspace, and I know I've reached that when I no longer feel bone and I feel myself engage with ligamentum flavum. Having engaged ligamentum flavum with my needle is now a matter of passing through flavum and looking for CSF. Notice I don't use a loss of resistance. I'm using the epidural needle as a spinal needle. Flavum will feel thick because I'm going through it obliquely, and then I get clear CSF. Having attained clear CSF, I now advance my spinal catheter. I do this gently, being considerate for paresthesia, and I don't want to feel any resistance. CSF will flow through the epidural catheter, but I find that it is a good safety tip to put the clip on and then aspirate CSF so that you can show your anaesthetic team that you've been successful. You should get free-flowing, clear CSF. Having proven that I'm in the dural sac, I now remove the clip, as I now want to remove the epidural needle. Taking care not to displace the spinal catheter, I gently remove the epidural needle. I now withdraw the epidural catheter so that only 3 to 5 centimeters remains within the dural sac. Too much catheter can have my catheter too high in the dural sac, and I can miss the sacral nerve roots, or worse yet, I could tangle it around a spinal nerve. Having withdrawn my spinal catheter to the correct depth of the skin, I now put the clip back on and make sure that I can aspirate CSF, and that I have not accidentally displaced my spinal catheter. Here you can see the midline approach. It is significantly steeper compared to the paraspinous or paramedian approach. Here the tip of the epidural needle might enter the thecal sac and have fast flowing CSF without being fully through the dura mater. When you try to thread the catheter, it won't advance, or, worse yet, it might enter the epidural or subdural space. This would lead to a failed spinal catheter. This is why we always aspirate our catheter. Free-flowing CSF out of an epidural needle does not guarantee successful catheter placement. I strongly advise against the midline approach. Here we can see the tip of the epidural needle pierce the dura. This would be associated with free-flowing CSF. Unfortunately, as the entire eye has not entered the dural sac, threading the catheter would be difficult, if not impossible. This scenario can lead to the epidural catheter entering the epidural space rather than being within the dural sac. Before placing a spinal catheter, I establish routine anaesthetic monitors and add an arterial line. I may give a small bolus of fluid as a preload, and then I will support the arterial blood pressure with a vasopressor. I make sure I have access to a timer to make sure that I take 5 minutes between boluses, and I have some isobaric 0.5% bupivacaine available. So here's Dad's recipe for using a spinal catheter in theatre. Your bolus dose is going to be 0.5 ml of 0.5% isobaric bupivacaine. You're going to wait 5 minutes between boluses. During that time, you're going to support the blood pressure with fluid and vasopressors. You're also going to monitor the establishment of the block. Once you've achieved a reasonable block, surgery can commence. You will need to repeat your bolus doses, and that'll be every 45 to 60 minutes. You're going to rebolus with 0.5 ml of 0.5% isobaric bupivacaine. You should expect that bolus to have its effect very quickly. It is not like waiting for an epidural bolus to establish. I'd like to end on some safety tips. When you're using a spinal catheter, always confirm that it is what you think it is. Once you've put the spinal catheter through the epidural needle, make sure you can aspirate CSF. Then once you've removed the epidural needle and you've withdrawn the catheter to the correct depth, make sure again that you can aspirate CSF from the spinal catheter. Now, it is essential to label your spinal catheter clearly with bright, easy to see labels. You need to avoid the catastrophic complication of someone else thinking your spinal catheter is in fact an epidural catheter. An epidural bolus down a spinal catheter could prove fatal. At the conclusion of the case, remove the catheter in theatre yourself and visualize the tip and record that this has been done. Finally, it is good policy to follow up your spinal catheter patients to look for post-dural puncture headache, although I would admit that this is vanishingly rare.
Congratulations, you made it to the end. Well, that was a bit of an epic, wasn't it? And I must salute your commitment. But here's the question I'd like to leave you with. Next time you've got a tricky case, where a single shot spinal feels a bit, uncertain, and a general anaesthetic feels like it could be a bit of an adventure, would you consider a spinal catheter? Just remember, if you're comfortable placing an epidural, you've already got the skills. You've got the hands. Put your catheter low in the lumbar spine and trust in the recipe, because after that, you've essentially got IV access to the CSF and all the control that comes with it. Give it a go on the right patient, on the right day, and I think you'll wonder why you didn't start sooner.